Hi, this is Dr. Bhargava. In this video, I have several interesting cases to share with you all. This is our first patient, and this patient underwent a DORA-TATE PET CT. We'll start by looking at the whole body rotating image. We see physiologic uptake in the pituitary. We see faint symmetric uptake in the salivary glands, uptake in the liver, spleen more active than the liver, and excretion from the kidneys into the urinary bladder. This patient had history of neuroendocrine tumor, and the scan is negative for a neuroendocrine tumor recurrence or metastatic disease. But the interesting finding is increased uptake in an enlarged left lobe of thyroid. And this finding can be seen with thyroiditis or multinodular goiter, like in this patient. So here on the CT image, we find that the left lobe of thyroid is enlarged, and there is patchy heterogeneous uptake from multinodular goiter involving the left lobe of thyroid. This is our next patient. We are looking at single frontal view of the chest, and here there is an opacity that is abnormal in the right lower lung zone. There is preservation of the silhouette of the right hemidiaphragm, and so this opacity is not in the right lower lobe. There is also preservation of the silhouette of the right heart border. That means that this opacity is also not in the right middle lobe. So it's somewhere in between, and this is the CT besides the chest x-ray that we saw earlier, showing a large hiatal hernia in the right lower chest. That was the cause of that opacity on the chest x-ray. This is our next patient. Here we have a PA view of the chest, and I tell my trainees, anytime you have a PA view of the chest, make sure you do the cardiothoracic ratio. So measure the maximum width of the cardiac silhouette and then compare it to the maximum width of the chest wall. This measurement of the cardiac silhouette should be less than half of the measurement of the chest wall. If it is not, like in this patient, you want to call enlarged cardiac silhouette, and this is their CT scan showing that they do have left ventricular hypertrophy because the free wall of the left ventricle measured more than 2 centimeters in thickness, leading to enlarged cardiothoracic ratio on the chest x-ray, causing or from left ventricular hypertrophy. This is our next patient. They presented with history of passing blood per rectum, and we performed a multiphasic CT. On the left, we have a non-contrast enhanced image. Then we have the arterial phase, the portal venous phase, and the delayed phase. And here we are looking for any contrast extravasation as the cause of active bleeding. And the arterial phase image, the portal venous phase is negative, but on the delayed phase, we see this contrast layering in a portion of the sigmoid colon, suggesting active bleeding or contrast extravasation. Here is another coronal reconstruction from the same patient, the delayed phase, where we find that this is the loop of the sigmoid where we see contrast extravasation. So they were actively bleeding, and most likely looking at the diverticulosis seen in the other segments, the cause of this bleed is diverticulosis. Okay, so moving on to a gastric emptying study. Here we are looking at anterior and posterior images at different time points, and we have used geometric mean to create a time activity curve. And so on the x-axis we have time, and on the y-axis, using the geometric mean, we have plotted the activity, and we're looking at the percentage retention at different time points. So because at the end of 1 hour, the residue is only 23%, this patient has accelerated gastric emptying, and these are the numbers we go by. And so for diagnosing accelerated gastric emptying or rapid gastric emptying, the criteria is retention in the stomach at 1 hour that is less than 30%. Most of the times we are looking at gastroparesis, so we use these other criteria and call it abnormal if the retention is more than 90% at 1 hour, 60% at 2 hours, 30% at 3 hours, and 10% at 4 hours. All right, so single ultrasound image of a testicle And here, when we look at the technologist labeling, this is a right testicle transaxial view in the superior portion of the testis, showing these hypoechoic, non-shadowing tubular structures. And this isn't a tumor. The vascularity wasn't increased on color Doppler images. This is a benign finding. This is called ectasia of the rete testis. So do not confuse this finding with a tumor. It may be unilateral or bilateral, and usually it is asymptomatic. This is our next patient. We are evaluating a transplanted kidney in the right hemiquadrant or the right hemipelvis, and we are looking at the peak systolic velocity at the site of the anastomosis. The velocity is very high, and you can see here that these waveforms are very high. And when we look at the iliac artery proximal to the anastomosis, the peak systolic value or the peak systolic velocity is 159 cm per second. Usually we take a ratio where we would divide this number 373 by 159. The ratio here is 2.3. So since the peak systolic velocity at the site of anastomosis is more than 2 times the peak systolic velocity of the artery proximal to the anastomosis, we want to consider renal artery stenosis. And more distally, like right here in one of the arcuate arteries, we see a Parvus Tardus waveform, which is classic of post-stenosis evaluation. So putting those things together, we have a very high peak systolic velocity at the anastomosis, and distal to the anastomosis, we find Parvus Tardus waveforms consistent with renal artery stenosis. This is our next patient, a young female who presented with sudden onset of severe lower abdominal pain, and we performed a CT of the abdomen and pelvis. This is the fundus of the uterus, and here on the coronal image, that's the urinary bladder. So anterior to the fundus of the uterus and also superior to the urinary bladder, we see this very large, ill-defined, heterogeneous mass with internal hyperdensity, which is consistent with hemorrhage. And so ovarian torsion can give rise to or lead to hemorrhage, and that can look like this. This patient was taken to the OR and they found ovarian torsion and hemorrhage. Here's our next patient. We have 2 images, one of the ultrasound on the left showing a normal appearance of the right testicle, and the left testicle appears enlarged, and there is a complex hydrocele around it. And so this is a transaxial image in midline from the ultrasound, and this is a corresponding image from the CT of the abdomen and pelvis showing hyperemic and enlarged testicle on the left side and the hydrocele. So this CT shows the classic appearance of epididymoorchitis seen on the CT scan, and with a good correlation with the ultrasound. This is our next patient. They presented with left lower quadrant abdominal pain, and the findings are classic. We see some diverticulosis, and around the colon, here's a sigmoid colon going that way. We see focal free air and surrounding fat stranding. So they have contained perforation from diverticulitis. Also, as we pay attention to these images, we find that that's the urinary bladder. It's abutting a part of the inflamed colon, and we see foci of air and abnormal enhancement where this loop of bowel abuts the superior wall of the urinary bladder. And we know that a fistulous communication between the colon and the urinary bladder is a common complication of diverticulitis, and this patient is probably going to develop that soon if this condition is not treated. So impending colovesical fistula from diverticulitis. Okay, so now we are looking at multiple images from MR of the abdomen. The contrast enhanced images are up there. DWI and ADC images are here at the bottom. And on the left, we have T2 weighted axial image and T2 weighted fat saturated axial image below. This patient images show a T1 hyperintense focus in the enlarged right adrenal, and that focus does not show any contrast enhancement. It does show restricted diffusion, and it's bright on T2 as well, and it does not contain any fat. So putting everything together, this is a hematoma in the right adrenal, and this patient did have a history of trauma which led to an adrenal hematoma, and the imaging appearance on MRI. This next patient presented with plain films of the pelvis in frontal and lateral views, and the history that came with this was a foreign body, and it seems like there is some kind of a container, and I'm drawing the outline of the container that they have inserted into their rectum, and it was taken out by the surgeons. This is our next patient here. The interesting finding, incidental, was that in the subcutaneous space in both buttocks there are these hyperdense foci surrounded by fat stranding, and so on the coronal image we get a better sense of these multiple hyperdense foci and fat stranding. And so these are from a cosmetic procedure. These are silicone injections for butt lift or enhancing the appearance of the buttocks, and they may lead to cellulitis and frequently abscess formation. Okay, so moving on to another MRI of the abdomen. Here the interesting finding is in the gallbladder. Take a look at this T2 weighted axial image. There are these T2 hyperintense foci at the fundus in a string of pearls appearance, and it's better seen here on the MRCP source image. So that's the fundus, and those are the foci abutting the fundus of the gallbladder. This is the reconstructed MRCP image, and this is the contrast enhanced image in the bottom right, showing that there is no enhancement inside, but there is some surrounding or septal or mural enhancement. And this finding is consistent with adenomyomatosis of the gallbladder that is benign, and it is seen as T2 hyperintense foci like we see here with no contrast enhancement. Here's our next patient. They presented with right upper quadrant abdominal pain. We performed an ultrasound, and in this transaxial image of the gallbladder, we find that there is mural thickening. There are these shadowing stones. And on the second image, we find that the CBD is dilated, and they were able to trace it to this obstructing and shadowing stone. And so this is a very rare finding. Choledocholithiasis, however, is very common when the stones pass from the gallbladder into the cystic duct and further down into the common bile duct, leading to obstruction. But those obstructing stones are typically not seen on ultrasound. They are usually better seen on MR of the abdomen, especially the MRCP sequences. So this is rare where we found choledocholithiasis on ultrasound. This is our next patient, and we have a whole body bone scan image on the left, which shows that there is no evidence of osteoblastic bone metastases. We see soft tissue uptake of the radiopharmaceutical technetium-99m MDP in the right breast, and when we correlate that finding to their CT of the chest, we find that they have breast cancer, which is right here. There is associated overlying skin thickening, and because tumors have increased blood supply, there is hyperemia that leads to uptake of radiopharmaceutical, which is technetium-99m MDP. This is our next patient, and we have single image from their thyroid I-123 uptake and scan, which shows uniform uptake in the left lobe of thyroid, and on the right side there is a nodule. There's a focus of photopenia that corresponds to this nodule that is seen on the ultrasound. And so their 24-hour uptake was 80%. So their diagnosis is Graves' disease. They were clinically hyperthyroid, and their TSH was low. But this patient should not be treated with I-131 for their Graves' disease without knowing if this nodule in the right lobe of the thyroid is benign or not. So they need a fine needle aspiration of that nodule, and if it turns out to be benign, then they can safely proceed towards I-131 treatment for their Graves' disease. This is an interesting DEXA scan. We have the image of the lumbar spine and the image of the right hip. The lumbar spine image shows that the T3 vertebral body has a height which is smaller than the one vertebral body above, L2, and the one below, which is L4. So when we compare this finding to their prior studies on the plain film, we find that in the lateral view they have compression deformity involving the L3 vertebral body, and so this would be an insufficiency fracture. When we look at the numbers from their right hip, we find that they have osteoporosis because their T-score in the region of the neck is less than or equal to minus 2.5. So they have osteoporosis and they have an insufficiency fracture. This is our next patient, and we're looking at a barium study where they have swallowed the contrast and the contrast opacifies the stomach, and we find that the duodenum is very dilated up to the part here where the C loop crosses over to the left side of the midline, and the follow-up CT on this patient shows a similar finding where the stomach is distended and the C loop of the duodenum is dilated up to this point, and then on the sagittal image we find that the angle between the aorta and the SMA is very narrow, because of which there is obstruction to the second portion of the duodenum as it crosses below the SMA or posterior to the SMA from the right side to the left side, and this is called SMA syndrome, and these patients typically need surgery for their bowel obstruction. Because they've had it for such time, you will find that these patients are generally very slim and they don't have much subcutaneous or intra-abdominal fat. Here is our next patient, and they've had a CT of the abdomen and pelvis. We are evaluating this transplant in the left hemipelvis, and at the level of the urinary bladder, we find that there is mural thickening, there is mucosal hyperenhancement, and this is the site where there has been anastomosis of the ureter to the superior aspect of the urinary bladder. And so they have cystitis, and usually it's an ascending infection, and then it can go through the anastomosis site to involve the kidney. So we find that there is mural thickening and enhancement of the ureter and the collecting system, and we also find that there is patchy hypoenhancement of the inferior pole of the transplanted kidney, suggesting acute pyelonephritis. So this patient has cystitis and acute pyelonephritis involving the transplanted kidney as seen on the CT. Thank you for watching.